Gunasekharan.
Chairpersons and my dear friends, today I am going to talk about step-wise transforaminal endoscopy stitchless span surgery done under local anesthesia, focusing mainly on the workflow of the procedure and the safety as well as clinical endpoints. The core philosophy is simple. See how to treat the pain generator. You should not aim at the MRI, and operating under local anesthesia may help you to recognize the physiological pain factors, and pain is often inflammatory and it's not because of the compression. So we use in vivo visualization to locate the pain generator and then targeting the nerve-centric soft tissues and removing the only soft tissues and maintaining the body integrity, and thus we do complete service of the neural compression. So broad indications are there, and most of the symptomatic lumbar discectomy you can address right from the low thoracic to last mobile segments. And not only the degeneration, you can also address the discitis as well as recurrent pathologies. And for at least for beginners, you should not touch multi-level stenosis. So stepwise it is very simple. You can divide into 3 steps. Step 1 is clinico-radiological correlations, and you have to locate where is the symptom is coming from. And step 2 is fluoroscopic control of the and planning of the precise target landing. And step 3 is endoscopic decompression in aware patients. So in step 1, we have to decide whether we have to do surgery or not. It's not planning of the surgery, and based upon that we have to go. There are certain algorithms. If it is chemical radiculopathy, you have to give distal block. If it is phasotogenic, you can give medial bright block. And you have to do McKenzie test, and whether it is centralized or not centralized depends upon you can conserve it or do surgery. So MRI alone is not a deciding factor. To step 2 proper, you have to fluoroscopically guide our trajectory and then plan for the landing. So before starting, we have to counsel the patient properly so that patient will be very comfortable, and then patient can be self-positioned to give good confidence to the patients and more comfort. And then we go for radiological skin marking, where we are going to mark the disc level using CM. Transverse line and a vertical line are drawn. Along with that, laterally obliquity of the disc can be decided to see whether we can go for what is our depth and direction of the entry. So local anesthesia is infiltrated in all layers from the skin to periosteum. If wanted, we can give up to the distal level, and then safe landing is through the Kambin triangle, where we always safeguard our exiting and traversing the route. Let me run the video on the subtitle will describe the steps. For all cases, you need not do abdominoplasty. Once our target pathology is visualized, now we have to do control and precise manner. So here, in the third step, after endoscopic entry, here your static MRI ends and your real in vivo visualization of the pathology and we have to do, after preparation, we have to do physiological driven decompressions in awake and aware patient. So you have to do intervention towards the targets. The targets may be disc fragment or annular tear or foraminal compressions, or it may be a lateral recess stenosis or infection. So the surgical endpoint is free visible pulsatil dura and nerve roots, and the feedback from the patients, physiological confirmation in our patients, as well as we can probe the nerve using the nerve probe both endoscopically as well as radiologically. I would like to show few representative cases demonstrating the philosophy of the Transforaminal Endoscopic spine surgery. So this is the case of targeted discectomy, where we preserve the posterior annular structures and remove only the offending fragments, that is targeted fragmentectomy. So this is a case of severe L5 radiculopathy in the left side with a VAS score of 9/10 with a large migrated extruded disc. We have planned for transforaminal endoscopic. We have retrieved, after initial preparation, we have retrieved a huge fragment of disc which was compressing the nerve root, and after removing the disc fragment, single suture was applied. The patient was mobilized from the table itself. He got significant relief. Patient was mobilized from the theatre and asked to pump urine. His neurological safety was good. Other cases, this is the post-operative MRI. You can see neural compression is there, decompression is there with the posterior annular integrity. So his post-operative outcome was also very good, and the patient was discharged the next day. These are the other cases where stenotic symptoms can also be addressed. This is the right side radiculopathy causing huge lateral recess stenosis causing right side radiculopathy. So we address the lateral ligament flavum. So we talked on we did a inside out technique. We talked inside the disc and came out, and then buried the under surface of the superior articular process, and then removed the ligament of flavum, and then we expose the compressive nerve roots. Nerve roots are very free. So we can see the postoperative compression with a good decompression on the right side, which was symptomatic. This is also another case with the extension dominant low back pain, whose dynamic X-ray showed compression from the L4 L5 region, where the superior articular process compressing the nerve root. So here, complete 360-degree decompression of exciting nerve roots, dura, anteriorly as well as posteriorly done. So the same philosophy is applied for all, even for discitis and as well as annular tear also. We can address the annular tear. This is the case of L5S1 pathology, where annular seal this annular leak using biological Derwent plug. So patient mobilized the next day. You can see the post-op MRI, there is a complete sealing of the biological sealing of the annular tear. Similarly, discitis can be addressed. It is a safer method. This is the previously operated patient with the infected disc material. We remove the disc and we debride it, and we send for culture sensitivity. So in conclusion, transforaminal endoscopic spine surgery is not a procedure per se, but it is a pain relieving philosophy. While you plan properly and select the patient and then land the precise target, we can achieve good pain relief in awake and aware patients in natural corridor.
To learn more about spine and pain treatment, stay tuned to Tamil Spine Doctor YouTube channel.